Now, we are going into the treatment modalities and outcomes. To speak on this, we have the head of the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Giridhara Institute, Dr. Neena R. With her vast experience in the same, she'll be enlightening us on the treatment options.
Thank you, Deepa, for this opportunity. And it's a very vast topic, so I cannot do justice to it in 10 minutes. So I'll just touch upon some case scenarios we've had and hoping that you will get some cues about the treatment. So there is no one treatment for all. It's no one tailor-made treatment. You have to go by your clinical diagnosis, investigations, and other serological tests. So this was a 21-year-old male who came to us with complaints of transient vision obscuration since 2 weeks. The visual acuity was good, 6.6 and 6 pupils were normal, anterior segment within normal limits. So catches transient visual obscuration since 2 weeks. Okay, so this is the fundus. What does it look like? Definitely bilateral disc edema, disc changes with vascular changes, bilaterally hard exudates, looks like papilledema, right? Yes, looks like established papilledema. Okay, so we went ahead and did the fields. Now, fields were not exactly very good. You can see there is a large blind spot, but there is also central involvement. But of course, this was not very reliable because low test reliability was there. So we did an OCT. OCT, what does it tell you? OCT can show these retinal nerve fiber elevations. That's all in the initial stage. But the GCL told us that this was going on for some time. There was some GCL thinning. It's all in red. So yes, so this was a long-standing disc edema which was beginning to give, probably producing axonal degeneration. And if you don't treat it, it's going to produce optic atrophy sooner or later, even though the vision was good. So what did we do? We did an MRI. And yes, when you have a patient like this, what do? You do an MRI. Ideally, you should do an MRI brain with MR venogram. Okay, that is the investigation of choice in papilledema because you want to rule out a space-occupying lesion, you want to rule out a condition known as cerebral venous sinus thrombosis, which can also present like papilledema, and you want to rule out the more common idiopathic intracranial hypertension. So our clinical diagnosis is papilledema, which is confirmed, but there is an intraventricular central neurocytoma, which is producing obstructive hydrocephalus in this patient and raised ICT. So it is fitting into this. So this is a tumor which is arising from the choroidal plexus. It's a very slow tumor. It grows, compresses, and when the patient has developed an obstructive hydrocephalus, he has come to us. So it's an urgent condition, and we referred the patient to the neurosurgeon. Before the tumor surgery, you have to reduce the ICT. So they did a shunt. First the shunt for the obstructive hydrocephalus, then only the tumor surgery. So patient did well, but did have some GCL thinning because this was going on for some time. So it's not like that papilledema cannot produce visual acuity problems. If you don't treat it, it can. So this is a second patient. Came with headache, a 27-year-old young lady. She has had tinnitus for some time and she was going to ENT doctors for a long time. She was obese and clearly she has said she had a weight gain of more than 10 kgs over the last 1 year and her BMI was 30.1. Pupils were normal, color vision was full, anterior segment was within normal limits. So this is the optos picture. I'm sorry I don't have the CP, but I think you can still make out that there are fuzzy disc margins. And this was looking like papilledema again. So again, good vision, young lady, what is your diagnosis? We will think definitely about idiopathic intracranial hypertension. Yes, that's what I also thought. And yes, the visual fields were showing some central scotoma, but she did not complain of any defective vision, but her foveal thresholds were low here. You can see 27, 25. Now, OCT RNFL is helping you because its RNFL elevation is documented. GCL is good here. Look at the GCL. So GCL also you please look when you look at the OCT. If you have an elevated RNL but good GCL, you can be sure there is no axonal degeneration yet. It's just a passive edema. So yes, so we wanted to rule out SOL, CVST and IH. So we did the MRI. MRI was essentially normal, but these were soft signs for IH were there, like tortuous optic nerves, perioptic, subarachnoid, prominent spaces, partial empty cella. So MRI does give you some soft signs which are typical of IH, normal venogram. So this is probably IH. You can't treat her yet. You need to send the patient to the neurologist to get a CSF opening pressure with lumbar puncture. So she did undergo a lumbar puncture. CSF opening pressure was 30. So she was initiated on oral Diamox 3 times daily, along with weight reduction, which is very important. Even a 10% weight reduction can improve your symptoms and signs dramatically. So that's something we overlook, and that's something we need to give stress and tell the patient. So this is, you can see, you can follow up these patients with OCT. That's what I want to tell you. You can avoid serial lumbar punctures by doing serial OCT. So you can see the serial reduction in RNFL edema over 8 months. But you look at the GCL, it is preserved, which means she is not going into optic atrophy because you are reducing the disc edema, the raised ICT with the treatment. The RNFL is coming down, but GCL is preserved. And her visual fields improved with time. Patient 3 is a 37-year-old male nurse who was working in UK. He came with complaints of sudden decrease in vision in the left eye followed by the right eye. He had a history of URI with fever about 2 weeks back. Visual acuity was poor, counting fingers in both eyes. Pupils were sluggish. The left eye had an RAPD. Color vision could not be comprehended because of the poor vision. And if you see the fundus, what do you see? The right eye disc looks okay. The left eye, it is hyperemic. There is some edema, right? So in this case, an OCT will help you. Look at the OCT. The left eye, it is definitely showing an RNFL edema, right? It is showing. The left eye, it is probably borderline. And when you look at the GCL, it is borderline. Usually you get about 50s in young patients. It's about 40s. So is this papillary edema or symmetrical papillary edema or optic neuritis? But there was RAPD. Patient's vision is poor. So I would err in the diagnosis of a bilateral asymmetric optic neuritis here. So we did a VP. What did VP? Waveforms are very poor even in flash VP, but what you can see is that, the left eye, the latency is much high, 162 compared to the 114. So 125 is your maximum, that is you have it on flash VP. So latency is prolonged. Left eye had RAPD also. So I am thinking about bilateral optic neuritis here, and it was. So the MRI brain with orbits showed intracorneal optic neuritis in both eyes. He was sent for a serology, but we didn't wait for the serology. We gave him IVMP 1 gram for 3 days. In fact, we actually give for 5 days now, and then followed by oral steroids. He was also sent for serology. He came out positive for anti-MOG antibody, and NMO was negative. So this is a MOG optic neuritis. He was referred for LP. Subsequently, all investigations were done. CSF-OCP was absent. So a MOG optic neuritis diagnosis was confirmed. Slowly, the steroids were tapered off, and currently, the patient is on rituximab. So it's very important to do the serology in optic neuritis to distinguish whether it is a demyelinating optic neuritis due to MS or it is due to MOG or NMO, because the treatment is totally different. In MS, you give immunomodulatory therapy. In MOG and NMO, you give more of immunosuppressive therapy. So that is the difference. So at you can see the VP is improved eventually. The visual acuity improved to 6.6N6 eventually, and his disc edema resolved. Okay, patient 4 came with complaints of scotoma in the right temporal side since 1 week. So this patient was about 60 years old, diabetic, controlled, hypothyroid, normal TFT. So you can see there was right RAPD, visual acuity, the color vision was also less in that eye, left eye was okay. So this is a right eye, what is this? Diabetic middle-aged patient. This is looking like an AION, right? Non-arthritic AION. So we did a visual fields, and yes, he had an altitudinal field defect. So this is the typical NAION, and so we decided to do an MRI just to rule out other things and to be sure of our diagnosis. He was told to control his systemic risk factors and to evaluate for other conditions which could have precipitated this, and a close follow-up was advised. We didn't start him on oral steroids. Patient 5 is an obese young girl. She had a history of typhoid about 2 weeks back, and she was put on IV antibiotics. She was studying in Chandigarh, and there she was treated with antibiotics. She came to us because there was a blurred vision. I think it's 10 minutes, right? Yeah, blurred vision after the second day of typhoid attack, and she has been giving some history of transient visual obscurations prior to this also. So she was obese, so I had this thing in my mind. Visual acuity, right eye was 6.6N6, left eye was 6.24N8. So she had a left RAPD. Color vision, however, was kind of okay in both eyes. Anterior segment was within normal limits, though it was little slow in the left eye. So this is her fundus picture. Anybody can go for it. So this is definitely severe disc edema with hemorrhages, and exudates also are there. And there is what you see here, almost like there's a subhyaloid kind of a hemorrhage in the macula. So is this an established bilateral papilledema, or is it some neuroretinitis secondary to typhoid, was our diagnostic dilemma. So we did some ancillary investigations like VEP, and you can see that the waves were very poor, especially in the left eye. Both eyes latency was prolonged, and you could see she had tubular fields, which was more in the left eye. So I was thinking this is definitely optic nerve involvement is there. I need to treat her. This is not papilledema. At least this is not definitely. And she underwent a lumbar puncture. CSF opening pressure was normal. And so we initiated her on IVMP 1 gram for 3 days, followed by oral steroids, because my diagnosis at this time was a post-typhoid optic neuritis, because post-infective conditions can involve bilateral optic nerves and produce a papillitis kind of picture. But here she had more like a neuroretinitis kind of picture. So we followed her up. After 6 months, her visual acuity improved to 6.9 N6. Color vision improved. It was always better, but it improved. The briskness of the response improved. And you can see the fields were opening up, and she still has a little bit of visual acuity problem in the left eye. So patient 6 is a 52-year-old lady who came to us with sudden blurry vision of the left eye of 1 day's duration. And this is her left eye. She is 612 N6, and this is Opto's picture. I think you can see there is incomplete macular star in the left eye. So this is a typical neuroretinitis. So in neuroretinitis, you don't have to give them IVMP. You can actually put them on oral steroids unless it's bilateral and it's very severe. So that's what we did. We did all the tests, and toxoplasma. You need to rule out infective conditions. TB and toxo are the two important things that we rule out before we start the patient on steroids. So she was positive for toxo IgG. And so the consensus now is no need to start anti-toxo treatment. If you want, you can initiate them on any antibiotics. But the consensus now is if it's only IgG, you can straight away start oral steroids. Now, patient, this is the last patient. He was a 42-year-old gentleman. This is one more patient. This patient was a lady who came with severe headache to her OPD. She couldn't sit or stand. Such bad was her headache, and she had blurry vision. Hypertensive, but we checked the BP, it was normal. Visual acuity was subnormal, 636, 660. This is her anterior segment picture. She had shallow AC with immature cataracts. Intraocular pressures were high. Okay, so undilated, we just had a quick look. This looked hyperemic. I don't have the picture because she didn't want to be dilated. She was so unwell. So I was thinking, is she having some aneurysmal bleed or something? And immediately I sent her for MRI, and it came out normal. There was nothing. So that's when we decided to have a second look, and this is where OCT really helped us. What is this? She actually had. So it's a very important thing is you have to do a dilated fundus examination, see beyond the disc. So she has this condition in which you get multiple serous detachments, and what you see these RP undulations. She's not having any neurological conditions. She's having a VKH or a Vogt-Koyanagi-Haradas disease, because of which she's having multiple serous detachments, and these RP undulations are very characteristic of VKH. So she underwent IVMP for 3 days followed by oral steroids, and she's currently on azathioprine for her condition. So very important, please do not miss dilated fundus examination. So this patient, a 46-year-old male, came to us with black shade in front of the right eye. He said he had this for a long time. Now the left eye is also having a black shade. So visual acuity was subnormal, 624, 636. Near vision was also bad, N36. Pupils were ill-sustained in both eyes, but no RPD. Color vision was full. Anterior segment was normal. This is his fundus. So again, is it neuroretinitis or is it papilledema, advanced papilledema? A lot of exudation, right? So the first thing we did in this patient was to check his BP. And his BP was 190 by 110 because something told me that this is malignant hypertension. And we referred the patient to the physician. So it was going on for some time. So it had produced some damage to the GCL. You can see the GCL, I don't have the GCL, I'm sorry. GCL was getting thin. So systemic hypertension sometimes can present like this. If it's ignored, it can even produce, eventually optic atrophy. So the take-home message is case to case. You have to see your clinical evaluation is most important. Textbook descriptions do not always apply to all cases. And just in a nutshell, if you want to differentiate papilledema from optic neuropathy, bilaterality is more in favor of papilledema, but you can have asymmetrical involvement. Optic nerve function is mostly preserved in papilledema, but not in optic neuropathies. If you have bilateral optic disc edema, first thing again to rule out is there bilateral optic nerve involvement or not, if there is a problem in MRI or not, and if there is, treat accordingly. And in IIH, before you start treatment, always do a lumbar puncture and a CSF study. Thank you.
Thank you, madam. VEP is a very important tool in evaluating